Good afternoon, everyone. My name is Niharika Kapoor, and I'm an intern at the Mental Health Foundation Australia and will be your host for this webinar today. I begin by acknowledging the Wurundjeri Woi people as the traditional custodian of the land on which I live and work and pay my respect to them, their culture, and their elders past and present. On behalf of Mental Health Foundation Australia, I would like to welcome and thank each one of you for attending the Transcultural Perspective in Child and Adolescent Psychiatry. I would like to invite our presenter, Professor Soumya Basu. Dr. Soumya Basu is a child adolescent psychiatrist. He aims to cater to the mental health issues in the youth adolescent population and is well acknowledged in Gippsland for his expertise and leadership in Australia and adolescent psychiatry. Dr. Basu has trained in both India and Australia and has more than 20 years of experience in psychiatry. He currently works as a child and adolescent psychiatrist with Monash Health and was previously worked at Religion Hospital as a consultant psychiatrist for 14 years. Dr. Basu also worked in private practice. He is well acknowledged in Gippsland area of Victoria for his expertise in child, adolescent and youth psychiatry. Dr. Basu has 20 years of experience as a child adolescent psychiatrist. He has keen research interest in youth mental health, early intervention, development trauma, developmental disabilities, transcultural psychiatry, autism, psychosis, and association of personality disorders with neurodevelopment disorders. Dr. Basu has presented a number of papers in national and international conferences, webinars, and has been invited to provide keynote addresses from RANZCP. Dr. Basu is fluent in Bengali, Hindu, Urdu, and English. Please join me in welcoming Professor Soumya Basu.
Thank you, Niharika, for the introduction. So I will skip the acknowledgement of the country. And we are actually presenting a very sensitive topic, which has become more sensitive in the recent days. And we've got an upcoming election where the issues of race, racism, the acknowledgement of country itself is becoming quite an important topic. Hence, it is a sensitive topic, and I want to present this topic with the intention of about academics, but there are a lot of emotions and complexities associated with this issue, and but they're clinically quite relevant. So, as Niharika mentioned, I have this experience, the lived experience of biculturalism, the experience of migration, experience of raising a bilingual, um, bicultural child, and working in remote and regional Australia, which are quite relevant in understanding the challenges that we face in this field. Just a background, which you are all quite aware of, that it is one of Australia is the home of the oldest continuous cultures. 20% of Australians speak English other than languages other than English at home. About 50% of Australians have either been born or have a parent, one of their parents born outside Australia, and about 86% of Australians support action to tackle racism, yet 20% have experienced race hate talk, and which has a devastating impact on mental health, as we will be talking. And so the cultural and racial diversity in Australia, started, you know, started very early on, but then there was a white Australia policy. A lot of people had to go back. Australia has a complex relationship with South Islanders, where more than 62,000 people were kidnapped from their home countries to work in privately owned sugar plantations in Queensland. The stories which are not even taught or understood properly, but 60% believe that there is racism is of significant concern in Australia. There is a huge work in academics going on the impact of racism in mental health, and we need to talk about it quite openly, and that's what I'll be doing in this talk. And about who experiences racism, students who've got parents whose parents are born only in an English speaking country is quite low. But students where not English speaking background, they experience racism. It's almost like 45% to 19%, which is very interesting. And as mentioned, about 20% of school students experience racism. That can have a devastating impact while they're growing up. The aim of this presentation would be about talking about the issues of migration and mental health, the biracial identity, bilingualism, impact of colonization on mental health, the possibility of overdiagnosis of severe mental illness while dealing with patients from a culturally and linguistically different background because of the perception or not taking into account the cultural differences, the challenges of a culturally different clinician, the importance of developing skills in culturally sensitive practice, and the need for consideration of cultural formulation when you are seeing patients, and why this is important, why this background is important in Australia, because there is ongoing access and equality issues in the CAL group. I work in the public mental health services in a most culturally diverse parts of Melbourne, but access to the services here are impacted by the cultural practices. And often we get patients from a different cultural background when the problems are much more severe. And the lack of culturally inclusive mental health research in an Australian context. And the issues of marginalization, early intervention, the impact of intergenerational trauma and major mental illness, and the criminal justice system, as we are all experiencing in Melbourne, the impact of youth crime and how mental illness and youth crime are intersect, and then the over and the cultural impacts of that. If you go to a youth detention center, you will see an overrepresentations of the cultural and the CAL group, which we don't normally see in the streets of Melbourne. This is one of my research papers, which was published in 2019. It's from Gippsland, and understanding the multidimensional complexities that leads to mental health challenges. Uh, the contributing factors are variable on family conflicts and death, domestic violence, emotional abuse, intergenerational trauma, and the experience of racism, parents with mental illness, parents in a jail, out of home care system. So there are so many different psychosocial factors. But when we divide the Aboriginal versus non-Aboriginal group, you can see that out of home care is much higher in intergenerational trauma is higher in the Aboriginal group, but the experience of racism in the CALD and the Aboriginal group is almost very similar. Now, the discussion on the Aboriginal group is a different topic. It's a full separate topic, but it will come in this discussion because they are very much interrelated. I'll give a case example. This was a patient whom I saw. His name was an Anglo-Saxon name, and during the whole review, normally when I see the patient as a consultant, the patient has already been assessed by clinicians, and this patient had a couple of episodes of care with the child and adolescent mental health services, and I'm seeing the patient after almost 6 months of what looked like a treatment resistant situation, and lo and behold, when I went to see him in the room, he did not. He was olive skin child with vitiligo, and nothing like that was mentioned in the formulation even. And more, when I went into the history, this child is from a mixed heritage background. His father was Anglo-Australian, mother is from Malaysia, a Tamil Anglo-Indian Christian background, and the and the family has history of mental and physical difficulty. There is history of extensive racism and bullying at school. The family, the mother was highly educated. The father was almost not as educated as the mother. They just married, and they experience significant ostracization from their own community, and have lives in a white dominated area where the child has experienced the family has experienced a lot of isolation, and the child was diagnosed with autism spectrum disorder, and he had an outburst at school threatening to harm his peers and harm himself, and he was muttering to himself, and because he was muttering to himself, he was diagnosed with having psychosis. When we dug deep into his presentation, it was quite evident that he has, right from his childhood, he has never had a sense of belonging. He does not know his culture. His mother, who's a postdoc academic, had physical difficulties. She's from an Anglo-Indian background, but grown up in Malaysia, but from an Indian heritage. So her sense of identity was also very impacted, and she has also experienced, different levels of isolation and challenges. And she married a Australian white Australian man with a severe trauma, who grew up in a out of home care situation, no contact with the family, and with suspected learning difficulty, and uh, she married that person and has experienced domestic violence from that man. And so from that sort of a background, the child did not have a sense of self. He had significant anxiety, and while we went deeper into understanding him, it was quite evident that he did not have psychosis. He was suffering from severe anxiety. He had experienced trauma, and the muttering was almost, he was preparing himself to to answer back or challenge, and he showed, and it was more of preparing himself, but that was seen as muttering, and he was put on antipsychotic medication for with a suspected diagnosis of psychosis, and he did not have any psychosis whatsoever. And understanding his challenges took a lot of time, because we had to go into his early childhood, his developmental history, his mother's history, his father's history, his mother's sense of identity, and the impact of racism, colonization. The mother's family left. Also, the cultural minority in India, who have experienced ostracization in India because of their challenges, and then coming to Malaysia where they were culturally minor, and her sense of self that had to be looked into. And while we did that, that there was a curious probe with a lot of rich history was obtained, and that was very important in understanding. So, what is more important raised in this scenario? It is about identity, bicultural heritage, culture of the family, the acculturation stress, the child trying to find who he is, and then growing up in a situation with vitiligo, a skin condition where he's literally getting white patches in his face, and how he was delving and dealing with it, the parental helplessness, and whether his challenges and his withdrawn behavior led to the diagnosis of ASD, is a question, because we did not undiagnose. We didn't definitely undiagnosed him with psychosis and stopped the medication. We did not undiagnose the ASD. And then, but his psychosocial withdrawal was perhaps because of the trauma that he was experiencing, which was understood. And once that was understood, there was an improvement. And but it also challenges the role of psychiatric diagnosis as a label, the meaninglessness of a diagnosis without a formulation, and the importance of a curious probe of the culture of the family. And also here, we really dug deep into the role of the skin pigmentation, and the impact on his sense of self and identity. And and the way he was bullied by peers of his age, younger peers, people outside, and his perception of being different, and which he was different, and but uh, how how uh, how this was often not even acknowledged in the formulation and not even seen as a relevant part in his history, because he was being seen as an autistic child with psychosis, and how the story can be lost if we do not dig into the importance of these important factors, which is absolutely evident from where I see the case versus people who from a different cultural background often doesn't see, because perhaps there is a fear around around the experiences. So the traumatic experiences, that we know can lead to cumulative trauma or complex PTSD, are being bullied, harassed by others, a sense of not belonging, having your reality ignored. The reality that he's getting bullied is being ignored, dismissed, or denied, being shamed, rejected, being abandoned emotionally and physically. Intergenerational challenges, oppression, discrimination, heavy invalidation, and in heavy medical procedures like being put on an antipsychotic medication, medical abuse, neglect, and others. So many of those traumatic experiences that can lead to a more of a trauma presentation can be hidden and missed, by misuse of diagnosis, which we need to really think about. Uh, the migration experience of the family, mother's migration experience, when we went through that in details, it's an intergenerational migration. So the migration of a Christian Indian family to a Muslim dominated Malaysia, the life of that family, the mother's emphasis on education, and the she's a Christian, so she comes to a so-called a dominant Christian family, and then experiencing significant migration, difficulties, though she has a Christian name, a surname which is Anglo-Indian, yet she looks visibly different, and the impact of social isolation. And then she chooses a partner who's not an intellectual match, and who has got his history of trauma that starts much before the child is even born. And the impact of social isolation and the lack of access to extended family and social communication experiences. Parental struggle to adjust in the social cultural milieu may reflect the child's behavior. And there's overdiagnosis, and then the next level is not getting adequate help, because the public system is often not catered to those early intervention models in culturally different families until the situations go out of hand, and when unless you get psychosis. Very interestingly, in Monash Health in Elms, where I work, in the child psychiatry part, the we do not get so many overseas child group as we get in early psychosis group, which is dominated by people from the overseas group, where when that is fully psychotic, then they have to get help, and then and get involuntary treatment. So the early part of the intervention in which can be preventative is often lacking, and in the juvenile justice system, in the early psychosis system, and there is severe impact of the mental health outcomes where it is overrepresented. I will just talk about the impact of colonization, and how it impacts the indigenous people, and then the impact of the migration of these indigenous people to countries like Australia, where the identity can be a major issue, the impacts of land dispossession, the losses of traditional land, spiritual practices. We see a lot of patients from the islanders, from Polynesia islanders, from Cook Island, and Papua New Guinea, and other a whole lot of people from Maori and Aboriginal population here. They, especially those patients, especially the islanders. You can the impact is double. There is this loss there, and please and acculturation stress in Australia. The social impacts of cultural losses, interactions with other Indigenous people, families, increased breakdown, domestic violence, violence against women and children, and a lot of people are migrating out. Mental health impacts is grief, depression, stress, distress, anger, frustration, feelings of hopelessness, and substance use, and the impact of industrial activities in the indigenous population, people in flux, non-indigenous people, money and short-term incomes and high-income jobs, big discrepancies, and then substance use, and impact on identity, cultural practices, and self-determination. And this is a complex slide on the impact of colonization and colonialism, on its impact on capitalism, supremism, which leads to a culture which can propose itself to be superior than other culture, which has created a lot of discrepancy through slavery, through cheap labor. We give an example of how more than 60,000 people were abducted from their homeland and brought in for cheap labor in the country. The impact on that with the idea of supremacy, which can lead to that humans are superior than others, leading to ecocide, destruction of natural resources, which can lead to more trauma and the intergenerational trauma. People are coming from countries which has been colonized into here, and that itself is a legacy of generational trauma that needs to be understood and talked about. Definition of colonization is colony is a territory tied to a sovereign state, no foreign policy or military. Sometimes the internal affairs are also determined that, and colonialism is a state imposes political, economic, and cultural systems on another territory and may encourage settlement. And the impact of that is not just lands being possessed, wars being lost, but entire culture. The colonization can happen through every means, through architecture, through imposition of art, history, education, and how the dominant force can annihilate the existing culture of the other population, and the impact of the people who are being impacted by um, such powers of colonization will come into fusion, and children are caught in the middle often. Then after coming, the dominant culture, the push is for assimilation, integration, and that can itself be such a big challenge. There for people from migrant families, there are multiple fact challenges: poverty, poor schools, neighborhood violence, discrimination, the impact of colonization, disparities in access, healthcare, NDIS, education, and jobs, and all these factors are associated with poor psychosocial outcome. Yet there is a construct called the immigrant paradox, that there are protective factors, religion, community, optimism, the dual frame of reference, high value in education, high resilience. But there's the second generation, not the first generation. The first generation are much more, they are often seen as having a better mental health. And the second generation are much more, they are dealing with too well reference frame, and there is higher rate of mental health difficulties in second generation children that we are dealing with, and including psychosis. The major challenges in providing care for the migrant families, this whole construct called differential acculturations. Children get much more acculturized much earlier on. The parents sometimes hang on to their own concept of culture, and sometimes culture is a moving term. They feel that the time they've left their own home, that remains their concept of their own home culture, and then there is a big cultural differences between the parent and the child. the languages of communication in the family. Often, and this is unbelievable. I've seen parents and children don't speak the same language, and they use Google Translate to talk to each other. This is an extreme case, but I've seen two such patients, which is not that extreme. And then while assessing the use of culture, and then use of um, interpreters in interview taking, in treatment, the use of language, and then providing planning and family therapy. It is incredible. I do a lot of autism assessment, and I for a person who's fluent in English, it is a breeze. But when we have to do the entire autism with an interpreter, the same thing, it takes about um, 2 to 3 times more time, to go through those nuances of understanding. So it is pretty complex when language is a problem. Now I'll talk about this. This is one of my most favorite slides, is the language of parenting and the lost in translation. And we see a lot of families, especially from South Asian background, which has been impacted by colonization. In India, it is, if you don't speak English well, you're not seen as very smart. And hence the parents would encourage children to speak English, and which is seen as cultural pride, that my child can speak English so well. And therein the problem starts, where the children are not encouraged to speak in their mother tongue. They lose their mother tongue. But the mother tongue encodes and regulates the first emotional state. The mother doesn't sing a song in English. From my Indian background, we often, to regulate the child, they would be talking, the first emotional regulation and encoding of the regulated state is done with the mother tongue. The poor mother tongue can result in emotional dysregulation, because the mother may not have the nuanced language to regulate the child. At home, intact interpersonal communication modulates behavior and emotions. And when the parents are unable to talk to their children, they cannot convey their values, their beliefs, and most importantly, their wisdom. But then there is a devalued view of many languages, which is done, which is a default state, for people who are so dominant with the L1, with English, and that loss of L1 in second generation migrants is common, and it's ongoing. And there is that can happen because of early exposure to English. People are being sent to daycare. There's a constant issue. People from migrant background, they have children. There's a rental pressure or financial pressure that the mothers have to go back to work. They send the children to early and childhood care, where everything is English. The parents, I mean, working in factories with their English is not that good, and the problem starts there. And as soon as the second child is born, both the children start speaking in English, and often the firstborn can have a better first language than the second born, and then this is lost. The linguistic environment at the home influences later language development. The maternal language ability leads to a large variations in child's vocabulary. And this is so important while understanding this. And the lived experience that I have is, while raising a child in this country, where the amount of communication that you have to do with school, and then the parents who do not have that privilege, the impact of that can have on the children. And then how the parents cannot even advocate on the child's behalf. The children have to grow up much faster, and then they become the interpreter for the parents, and the role reversal as a result. The societal pressure to lose L1, it raises ethical issues. The development of L1 is associated with family cohesion, intimacy, parental authority, and transmission of cultural norms. And the L2 development is related to long-term academic success and economic outbeing. And the balanced approach is very important, but often the loss of L2, where L1, which is the mother tongue, is not even seen as a problem, which is a huge problem with mental health as time goes on. The contextual interpersonal communication skills versus decontextual academic language proficiency, and the aim has to be that balanced bilingualism, and but even recently, even about 15-20 years ago, the parents were actively encouraged to talk in only in English, which can cause such a huge damage to the child, and especially the relationship. They can lose their identity, lose their cultural heritage, lose their entire heritage. I'm a Indian. I speak Bengali, and there's an entire world of Bengali movies, songs, emotions, which cannot be 100% translated into English. It cannot be, but that can be lost if you do not put a huge emphasis on this balanced bilingualism. This whole issue around assimilation versus inclusion. The assimilation pressure is that we have to come here, forget their language, adapt footy and support a footy team. That is how it should be. The individual is treated as an insider in a work group when he conforms to the dominant culture and downplays his uniqueness. And in inclusion, individual is treated as an insider and is allowed and encouraged to retain the uniqueness within the working group. Um, from a from here, we need to go into the culturally informed clinical assessment, use of linguistic interpreters and cultural consultants for individual therapy and for family therapy. Individual therapy with the children, it's not difficult, but with the person who doesn't speak English, it becomes so difficult, and especially family therapy, which is the most important part of working in childhood, in families. It becomes such a big pressure. The the reasons for assessment, we need to understand whether it is adversarial, is it involuntary. If the parents are perceiving that it is an involuntary, sometimes the cultural practices like physical disciplining, can lead to a child protection notification. And then there's adversarial fear around assessment, and how difficult it is to get any information from the families who are terrified that the children will be removed, and how much difficult it is to translate that, and then the nuances of therapies, which are very Western dominated models, how to implement that in a cross cultural group becomes very different, and there's such a legacy of children being removed in this country for last so many years, and how what do the child protection system represent in the cultural and scale group, and also from Aboriginal group. It's quite a history there as well. um, this unequal treatment, as a therapist, we are at a much advantageous position. The clinician's self-awareness, I was shocked that, as you can imagine, with that first case where nothing, the cultural differences of the child was not even mentioned in the formulation. And often the self-awareness of that, people just, I'm seeing a Vietnamese person, and we use a Wikipedia to understand these are what Vietnamese do, how it can relate to stereotyping due to cognitive shortcuts, and rather than learning from the family, and being aware that we don't know. And the problem is that during the entire curriculum development of the children, right from the very beginning, if the families are not very aware, or they're not traveled, or the children are not exposed to the other cultures, often this lack of awareness is not even, people are not aware of the lack of awareness. And this is what I see with a lot of young clinicians, postgraduates from the top universities here, without and doing psychology. And social workers are a little better, but especially psychologists, coming, they're not even, so psychologists, occupation therapists, speech therapists are a little aware, because they get a lot of other cultural groups as well. But often some of the most important professionals who are working with these children, that is absolutely not a lot of training in the transcultural aspects at all, and that can have a big impact. The effectiveness of real therapy is associated with knowledge about the background, ability to form the parent and patient family centered awareness, using the family's norm and unique perspective. In the assessment, it is important to understand how culture influences the child's and the family's understanding, the beliefs, attitude towards treatment. Are they being coerced? Empowerment remains the key. The strengths and the needs of the family, the idioms of distress within the family needs to be acknowledged, and then the differential expression of normal emotions. That is different in different cultural groups, and that needs to be acknowledged and be curious without being um, trying not to be the expert there. Um, Now, addressing the assimilation and cultural acculturation stress, the impact is different for different family members. The way the mother reacted to coming to Australia can be different from how the father reacted, and then the differential acculturation, the children becoming much more Western. And they would say that, why did you bring me to Australia then? When I'm trying to accommodate and going out, then the parents are putting in huge barriers in the acculturation process, and this is common in every country. I mean, parents in India, they are worried about their children's safety and modernization and going out and dressing in a more skimpy manner. But here it is a little bit more forward-looking country, more westernized, and there can be a even bigger, conflict between the parent and the child. The transgenerational impact, of colonization, as I've mentioned, because people coming from South Asia, which where I'm coming from, there is a intergeneration, so huge 200 years of European rule in many of the countries. I mean, the whole of South Asia, Southeast Asia has been impacted by, and the entirety of Africa and South America and even North America have been affected by colonization, and the impact of that on a generational impact of that is important to go and understand the acculturation, stress like discrimination, marginalization, and and from the majority culture and the youth's own culture. Sometimes they don't even belong to any of the culture. They are in the middle. They don't belong to their own culture, and they are marginalized from the majority culture. The history of migration trauma, the traumas and difficulties before migration. I mean, for refugee families, it is unbelievable. And I work with a lot of Sudanese families, a lot of Afghani families. When they talk about trauma, they feel trivialized when we talk about trauma, because the whole culture has been traumatized, and the journey, during the journey, often from southern Sudan, they have walked through Ethiopia, experienced horrific traumas, child soldiers, you know, attacked by wild animals, then living in, um, then going in, refugee camps in Kenya, and before coming here as a UNHCR um, visas as refugees to Australia. The trauma of that is important. The subsequent arrival, the traumatic separations, the survivor guilt, coming to a new culture, leaving the family there, the reunifications with family members, the social uprooting, losses, abrupt geographical relocations, and then their parenting rearing purposes, punitive, abusive rearing styles, which has an impact. This is a very interesting thing about how it is important to the sense of culture mistrust and distance from a dominating culture, which is not just here, but the culture of domination in their own country, and how that has been impacted the discrimination and oppression related insults, the status anxiety, social evaluative stress, inequalities, and access to material resources, the internalization and application of oppression, the salience of the traumatic distal narrative of an event, and the historical intergenerational context of trauma, and how it is all interlinked. And we need to really understand that, while we're doing that. And it's just not, it is not just a hobby; it is a must. We are in this profession where it just cannot be a fringe incident. It is core knowledge. In DSM-5, there is a whole section on cultural formulation, the cultural and identity of an individual, what does belonging to the group means to the patient, cultural explanation of the illness, somatic versus Western mind-body separation, which is it's a Western model, the psychosocial environmental impact of functioning, intergenerational conflict, the therapeutic relationship, the clinician child and parent relationship, overall cultural assessment and diagnostic care, accepting the dynamic attitude and to new information and monitoring. And this is very important, that each family members are, their legal status and reasons for relocation, values about structure, power, myths and rules, values of education, religion, cultural institution, food, clothing, oppression and discrimination, languages spoken at home in the community, health beliefs, impact of trauma, substance abuse, and other crisis events. From a training impact, the impact of racial discrimination on mental health needs to be talked about. The skills to challenge stereotypes, particularly about the dangerousness and violence, often aligned to negative cultural stereotype, reflective skills, and case study analysis of practice issues should be a part of the training. The relevant concepts are cultural competence, cultural responsiveness, cultural safety, and most importantly, cultural humility. Cultural humility is about cultural awareness, self awareness, and cultural diversity awareness, cultural identity awareness, cultural skills assessment, cultural knowledge, and cultural sensitivity. This is a tremendously important concept, by Trevelyan Murray Bracia, to promote the concept of cultural humility, representing and eternal commitment towards self-evaluation and self-critique to readdress the power imbalances in a patient-physician dynamic, to develop mutually beneficial, non-paternalistic clinical and advocacy partnerships with communities on behalf of individuals and defined populations. Now, the issue, I mean, while working with indigenous groups and people who have been impacted by decolonization, this concept of neural decolonization, this is this is very popular in New Zealand, somehow not that popular in Australia. There is a academic, a social scientist called Michael Yellowbird. I have had the privilege of going through his workshop on neural decolonization, where with the total cultural healing, the challenging of the colonial narratives, reclaiming and acknowledging the indigenous knowledges, developing a critical consciousness, embracing a pluralistic worldview, recentering indigenous languages, and shifting to objectivism, contextual understanding is one of the end games, very important in cultural healing. And this is more true for Aboriginal people, but often important in working in families who have been impacted, and most of them are with colonization. Now, this is for infant mental health. There is a substantial evidence for a cradle to prison pipeline, which suggests that social inequalities begin in early childhood. Preschool expulsion rates for Black kids are 3.2 times higher than in white children, and the black children represents 18% of enrollment, but 42% are suspended once, and 48% of suspended more than once. This is from US. We do not have such data in Australia, which is of importance, great importance to have research in this area. As Winnicott said, there is no such thing as a baby. A baby cannot exist alone, but essentially is a part of a relationship. Lieberman Chow Van Horn Harris says there's no such thing as a family. A family cannot exist alone, but is essentially a part of a social, economic, and cultural system. There is no such thing as a provider. A provider can exist alone. Our reactions, interactions with families are shaped by social, economic, and cultural systems. Past informs the present. There's this powerful article called The Ghost in the Nursery. And then Ghost Ipen writes about the ghosts in our society and acknowledging that atrocious cultural experiences, the original ACEs. The original ACEs, atrocious cultural experiences, the experiences of genocide, slavery, colonization, forced family separations, sanctions, attacks on individuals' body, removal of property and land, and denial of basic human rights. In the diversity informed tenets of work with infants and children, self-awareness, champion child's right globally, work to acknowledge privilege and combat discrimination, recognize and respect non-dominant bodies of knowledge, honor diverse family structures, understand that language can hurt or heal, support families in their preferred languages, allocate resources to systems change, make space and open pathways in advanced policy that supports all families. So often, this is one of the most important model that I'm very passionate about. My one big area of interest is children with parents with mental illness, and where we do dyadic work with child and the parent. And this dyadic work is the basic work in infant mental health when children under the age of 5. And in the child parent psychotherapy, the core principle is to be able to speak the unspeakable. It's not what is wrong with you, what has happened with you. And if we can extend that into cultural groups, is acknowledge the history and act to restore the safety and justice within the current system, working towards in trauma-informed care. This is not what is wrong with you, but what has happened to your people. Thank you. I can now take questions, and I think I've finished on time. I've got about
Yeah.
10 more minutes. I don't know whether we need to take questions or will it be open to the
Thank you,
listener.
Professor Soumya Basu, for presenting. Thank you, Professor Soumya Basu, for presenting a very informative presentation on transcultural perspectives in child and adolescent psychiatry. Now, I would like to take a moment to thank each and every one of you for joining us for today's very highly informative webinar on transcultural perspective in child and adolescent psychiatry. As a part of your professional development, a certificate of attendance will be emailed to you very soon. Bye for now. Thank you.